Hi, I'm Dr. Joanne Smith.
And I'm Dr. Corinda Hankins.
And this is a pod full of pediatrics. Subscribe here for more content.
Or go to onecommunityhealth.org.
Or follow us on social media at One Community Gorge. And this is the one where we talk about
RSV prophylaxis. Sorry.
This is when we talk about RSV prophylaxis. And the word prophylaxis means prevention. So this is where we're talking about not getting RSV.
Right. And or like basically helping you kind of effectively fight RSV with once you do get it.
I was like, what else does prophylaxis mean? What else are you going to say?
But it is not, the reason that we make this distinction instead of the other one is that normally we've talked about vaccines and RSV is the prophylaxis that we use isn't actually a vaccine.
No, it's a medication. It's a monoclonal antibody.
Right.
So RSV is Respiratory Syncytial Virus, and it's a leading cause of lower respiratory tract infection in kids that are less than 1 year old. And the leading cause of hospitalization for them.
Yeah, it is. RSV primarily causes bronchiolitis, which we talked a little bit about in the last episode. It is inflammation and snot.
So much snot.
So much snot. Ton of mucus production.
Anytime your baby has just like total snot constantly, you're like, it's probably RSV.
That's right. They have swelling of the smaller airways in the respiratory tract that leads to wheezing, coughing, crackles. Like they sound yucky and junky.
They feel yucky.
And they feel. It can cause fever and it can result in significant respiratory distress. And in little tiny babies.
Yeah, when they get it like less than like 2 months.
Yeah, and they can't clear their airways. They actually just stop breathing.
Yes.
It can cause apnea. So RSV is one of the most common causes of hospitalization.
And such an annoying disease, right? Because it's been around forever and we still don't have a good treatment for it.
No, we still, after all these years, it's the most common cause of hospitalization in children in winter. And we don't have great treatments for it. Again, we don't have a cure, so we just do supportive care.
And nearly every child will get RSV before age 2. Like it's just super common.
Yeah. And there's an estimated like 58,000 to 80,000 children a year younger than 5 who are hospitalized due to RSV.
Prior to 2024.
Prior to 2024.
Yes.
And there's a really good reason for that.
Yes. So mortality is rare from RSV in the U.S. because we have good supportive care, but globally it is a pretty common cause of disease for kids.
Yeah, and can cause, it's actually the cause of 2% of deaths among neonates less than 28 days of age globally, and 7% of deaths among infants 28 to 1 year of age. And then 2% of deaths among children 1 through 4 years of age. So it can even be a cause of death for older children. And typically that's because they have trouble breathing. And so they get pretty respiratory distress because again, you have all of this inflammation and snot in those lower airways and they just can't oxygenate and get air in and out the way they're supposed to. And so we give oxygen, but sometimes you can't overcome that like kind of
mucus production.
And here in the US, we suction a lot, which is awesome. And they do that in most places. We can give IV fluids if they're not like drinking enough and actually even food like by the veins if they can't eat well or down into the tummy directly. But the big thing that we do is we give this kind of flow.
High flow nasal cannula, which is imagine just having a fire hose of air shoved up your face and you're just, it stints open your airways, great, but it feels terrible.
And it does allow babies to get air in and out, but it is not comfortable. No. And that is actually our major sources of treatment for infants and children with RSV. And again, it's actually very, very good treatment in the US. Because our mortality rates for RSV are small here, but it is a huge issue with hospitalization still. Yeah. Again, the major cause of hospitalization in the winter.
Yes, and leading cause of infectious disease between 1 month and 1 year globally other than malaria. Yeah. So it's a big deal.
It is a big deal. And so we talked about all those things that we can try and help with treatment. But what we found
is prevention is better.
It is. And we're going to kind of always talk about that because, again, we would like not to
eliminate our own profession, right? We're
right.
just like, let's just get rid of it by preventing everything.
That's right. So then we don't have to admit kids to the hospital. We don't have to watch them really suffer through this. And so the original, I mean, we've been trying to like find a vaccine.
We being like the pediatric community.
Yeah,
not us
infectious
personally.
disease community.
Yes.
And like have been trying to find really a way to prevent RSV for, decades.
Decades,
right. And so it's gone through many iterations, but we haven't actually ever been able to find a vaccine for it.
No.
So meaning like a antigen that allows the body to make the antibodies itself and prevent it. Instead,
so they monoclonal antibodies. And so in 1998, Synagis was approved for premature infants, which it's a monoclonal antibody.
Which basically just means that we're giving you the little antibodies that you need to treat the infection once you get exposed to it. And so it kind of gives your body a leg up until it can make its own antibodies to the virus it's being exposed to. And so that's really important for premature neonates, for infants or children with like chronic lung or heart disease, because they have often the most trouble with this because they don't have the good breathing mechanisms to get out
when they have a regular cold, right? And then you have RSV with so much more snot, and it really makes it hard. And so Synagis was approved in 1998, and quickly they saw a big risk big reduction in the risk of hospitalization for these premature babies. It went down 55% within 3 years after approval. And what we saw at that point was the premature kids were not getting hospitalized with RSV, and now the term babies were being hospitalized with RSV.
And they were always being hospitalized with RSV, but like, again, it just wasn't making a difference in them because we couldn't give it to them. And there's a reason why we couldn't give Synagis to everybody.
It was given every month through the RSV season, usually October through March. And every month the medicine costs $1,000 to $1,500. And so insurance doesn't like to pay that.
Right. I mean, it is one of those things that they didn't feel like the cost of the every monthly treatment for every child for Synagis was worth that reduction.
Even though it was a very good treatment or a good preventive treatment.
Right. And so we've been still trying to find another answer. And then finally, 2023, yay! We have a new version of the monoclonal antibody.
Yes, and it can be given to kids given to babies. That's called Beyfortus, or it can be given to pregnant moms, and it's called Abruzio.
I think it's Abruzio. Yeah.
Abruzio. We don't say that word very often because we don't teach pregnant people.
That's
whatever.
Right.
Yeah. Beyfortus is what we know.
That's right. But basically it's given, the nice thing about this is that it lasts longer in the system. So the antibodies are not broken down as quickly. And so it can actually last 5 to 6 months.
So it's just a one-time dose.
It's a one-time dose.
The monthly dose.
We recommend it for all babies less than 8 months.
During the winter season.
During the winter season, unless the mom's got it.
Right.
So moms get it, the Abruzio, and Nirsumab. It is given during pregnancy, basically between 32 to 36 weeks gestation.
Yes.
And that actually then the mom has those antibodies and passes them to the baby as the baby's born. And that is as effective and about the same time length as the Beyfortus.
Right.
So Beyfortus is really only used when moms don't get
the vaccine, or it's been long, we go up to 8 months. So it's been a while since the baby was in utero.
Right.
They can have it for the winter season.
Yeah. And so sometimes too, again, moms are only given it during the winter season. So if mom was pregnant in August,
right,
then we don't give the antibody to mom. And so the baby will still be less than 8 months in October when we would give the Beyfortus. So again, any baby any infant less than 8 months can receive Beyfortus, and it lasts all the way through the RSV season. And it's been
great. And so the first year it was available was 23. It was hard to find, but this last season, 24 to 25, is when we actually were able to give it. And they saw a 52% reduction for babies 0 to 2 months of just even having RSV.
Yeah, it was a huge
huge difference.
And you were noticing that, like decreased hospitalizations, we had decreased admissions.
Right.
I didn't have to admit as many babies last year.
Decreased babies having RSV.
Yeah, it was really amazing. It was the first time where my whole winter wasn't RSV, which is really nice, actually. Yes. And I think we'll see more of that in studies of the last year.
Right.
But again, that just happened. So
yes.
so we got lots more time for that
to gather that data. And and it's again really well tolerated. We can give it the first week of life, and babies do great. No side effects.
Like no fevers. Like it works great.
And it just boosts their immune system so they can fight off the RSV once they're exposed to it.
Yeah, and so it is again a game changer for RSV, which we are, as you can tell, super excited about, because I really just love the fact that we're going to have to admit less infants.
Yeah.
So. But, this is another vaccine now that we give in infancy.
Yes, not a vaccine, but it's given the same way. It's a shot.
Yeah, so it's another shot we're giving in infancy. And so, we, like we talked about, after each vaccine we talk about, or antibody in this case, we're going to talk about, questions that we get from parents about vaccines.
And so a common one we get is, why do we give so many vaccines at one time? Why does each visit have so many vaccines? And isn't it dangerous to give them all together? And why can't I space them out?
And the vaccine schedule, this is really fascinating to me, because it really was not created for the convenience of medical industry.
It was not just random chance, right?
No.
Yes.
The current vaccine schedule is really the product of super thoughtful and informed collaboration between lots of different specialists, including pediatrics specialists, infectious disease specialists, and public health.
Right.
And it is truly all in the interest of your baby or child. It is based on, and this is really important to recognize, that it is when vaccines are best tolerated, safest, and offer the best protection for your child. And that's really how the vaccine schedule was created. It has nothing to do with when it is easier to give, or in nowhere monetary part of it.
It's what makes them happy, healthy, and safe.
That's right.
Those three things.
That's good. Happy, healthy, and safe. So, and that's really what it was based on. A lot of parents ask about the maternal antibodies, and that's actually one of the reasons we give them at 2, 4, and 6 months, is because your baby actually does have some maternal antibodies that cross the placenta and offer some what we call passive immunity. Just like actually the RSV prophylaxis is a passive immunity.
Right.
And so they get some of those antibodies from mom, but those antibodies get chewed up pretty quickly.
Right. It's also why we have moms have Tdap during pregnancy, right? Just to have the passive antibodies until the vaccines can actually help.
But by 6 months of age, the passive antibodies from mom are gone.
They're gone.
So they are not going to help baby fight infection anymore. And some of the ones that the majority of the ones we vaccinate for are particularly dangerous at that age.
Right.
When you're basically decreasing that protective antibody effect, and they can be really overwhelming for infants. And so that's why we give the vaccines at 2, 4, and 6 months. And what they found is that when we give kind of the smaller dose of antigen and boost the immune system with that 2 months, 4 months, and 6 months, by 6 months, now the babies have their own active immunity. They can fight it off.
And people ask about breastfeeding. Can I just supplement their immune system with breastfeeding? Yes, it definitely helps, but it's not as great as a baby making their own immune cells, which means they need exposure for that. And vaccines are that tiny little bit of exposure, enough that they won't have the side effects from the infection, but their body will know that disease when they encounter it.
And they are already making all those antibodies really quickly so that they can fight off that infection before it gets overwhelming to them. Yeah. And that's actually a really important distinction there. And some of those infections, pneumococcal, Hib, pertussis, are just way more dangerous in that early infancy stage, and can be really overwhelming to a child's immune system. And they're the overwhelming thing, not the vaccines.
Exactly. Yeah, the scary bacteria, they're the ones that are really scary to us.
And that's the thing about it, is that our babies actually are so cool, because as they come out of the system, they're in this very sterile environment. Mm-hmm. And then as soon as they come out, they get hit with a trillion types of different cells.
And that's not just exaggeration when people say gazillion. You're literally saying it's trillions. A mathematical thing. Trillion, right?
Trillions of cells of bacteria, viruses, yeast that comes through skin, nose, throat, mucus systems, all of those things. And they actually start making response to that simultaneously and right away.
Yes.
right? And so we get actually really good at it.
And we want them to have that. We don't want to keep them sterile. We want, your bodies to be exposed to the natural world and learn how to live in it.
The hard thing is that, the ones that we vaccinate for are ones that, like, if an infant was exposed, it really is more than we would expect and very hard for them to respond to those particular illnesses.
Right.
So we do pick the ones we vaccinate for. And that's because those bacteria can have just one bacterium of that kind can have 2,000 to 6,000 immunologic components, right?
Right.
And more than that for the really, really invasive or scary ones. And whereas the vaccines that we give, like all of the 14 that we find on the childhood schedule, all the way from 0 to 18, is only 150 immunologic components.
Right. It's so much less than the world around, and so much less than the actual infection.
Yeah, and even if we gave all of those together, which we don't, because we separate them out, right? That is so much less than what we're already being exposed to and what infants are being exposed to. So they can very much make responses very well without being overwhelmed to anything that we see in the vaccines. And the other thing I like to point out is that our vaccines are so much better.
Oh, yeah, so much cleaner, right? They don't have extra things in there that they don't need.
Right. And so before, when we tried to make immune responses, again, like we talked about in some of the other vaccine ones.
Yeah, like 40, 50 years ago.
Yeah, 40 or 50 years ago, they had a ton of antigens in them, a ton of those immunologic components, right? Trying to make that part. And then we found out we didn't need all of those. We could make them really tiny little bits of the virus or the bacteria that allowed us to make these great responses and not have any of the side effects.
Minimal side effects, yeah.
So that's really why they were developed that way, and why they're given in the times that they're given.
Right. And we have some combination vaccines now. We didn't before, which is try to just save some pokes, right? So and different companies make different combinations, but they're the same vaccines. They're just combined into one thing.
One little injection. And again, not adding in any different, there's nothing else in those vaccines when we give them together. They're just the vaccines.
Right.
They're just given together. And they have been tested and they don't cause any more increase of side effects or anything else. But they do cause less trauma.
Yes.
I mean, getting, 2 vaccines at 2 months and an oral one versus 5 and an oral is actually a big difference.
Less pokes.
Yeah, it is much less pokes. And then the other thing is that there have been some really good studies on, is it okay to split them up? Give one at a time. And,
kind of as pediatricians, we definitely don't advise that. I mean, that is more episodes of trauma, right, for your child, which not only is like physical trauma, just kind of split them up, but emotional trauma, right? It's stressful for them every time.
Yeah. And again, if every single time you come in, if you're giving a vaccine a week, then every single time they're basically, again, that means they're coming in 5 weeks at a time. They see you every 2 months. So they're getting a vaccine every single time they're coming into the doctor. And so you do remember that.
Yes. And then they really hate coming, right? Because they're like, every time I come here, I get hurt. Whereas if you spaced out, it's time for them to be like, okay, this place is not too bad.
Right. If you're getting 2 and it's one time and then you're done and you comfort your baby right away, babies actually tolerate these very well.
They do.
Yeah.
And then we also kind of know when people split up the vaccines for their kids, what happens a lot of time is they just don't come back. And so they ends up being that the babies don't get all the vaccines that they should get.
And they don't come back because they don't mean to come back. We know
life gets in the way.
Right. Life gets in the way. And one of the biggest things is that kids get sick, right? Like we talked about in the previous episode.
Yes.
5 to 9 infections a year, and most of those in the winter. So if you have a baby born in the winter and you're trying to give vaccines one at a time, they're sick a lot of that time. And most parents don't want to give a vaccine when their baby's
Though
sick.
it is safe to do it, but it's just safe. Not fun when they're not feeling well.
And so they don't come in, and then you just get further and further off. And there's actually some also really good studies that show that you don't get as much efficacy when they're all separated as you do when they're together.
Right.
So our body being able to like make that response all at once actually is really helpful to their response to the vaccine.
Yeah.
And so they make better antibodies and again have that active immunity, which is so important if they're getting exposed to these viruses or bacteria that's really, really scary and bad for them.
Protects them. Yeah. So we would recommend please vaccinate them with the recommended schedule.
Yeah. And it is very safe, very effective. And it is the best way to make sure your child stays safe, happy and healthy.
So I'm Dr. Joanne Smith.
And I'm Dr. Corinna Hankins.
And this is a
Pod
Pod
Full
Full
of
of Pediatrics.
Thanks for listening.